This video will cover pediatric pulmonary disorders in the pediatric population. We're going to just very briefly talk about the incidence of respiratory tract infections, and then we will focus primarily on asthma and cystic fibrosis. Both of those should sound very familiar to you since last semester we just talked about both of them in our cardiopulmonary and integumentary course. So you'll be able to apply a lot of the information you learned there, though you will have to modify it for the pediatric population. So just briefly, the incidence of respiratory tract infection, that's not what this slide is. Obviously, kids get respiratory tract infections pretty readily, and we've talked about the reasons why with infancy we might see respiratory issues, especially with premature infants not having a maturely developed, fully developed respiratory system. But even in kids who don't have any troubles like that, respiratory airway tracts in children are very small, so it's pretty easy for them to get clogged up with mucus when they're inflamed. Because of the ratio of the trunk size, they don't really have a very good mechanical advantage, so they don't have the strength and the endurance of the respiratory muscles that adults do. Alveoli development isn't really even fully done until they're 10 years of age, so that's pretty incredible. And I'm sure most of you know that infants do tend to experience a small drop in their immunity after a few months of age. Now, there is some support for research that shows breastfeeding can improve that, but still, as they're exposed to different pathogens, they're certainly susceptible to respiratory tract infections, viruses, things like that. This slide, though, is talking about prevalence of asthma among children. And this looks at state by state, as you can see, and Wisconsin's really pretty high. We have over 9.8% prevalence. I don't know why it doesn't go up any higher, but we have a pretty high prevalence of asthma. And as you know, asthma is characterized by spasming of the smooth muscle. And there's also, of course, an inflammatory component that goes along with that, but it's really characterized or set apart from other conditions of COPD by the smooth muscle wall contraction in the bronchioles. And of all the chronic childhood disorders, this is the most prevalent in the U.S. And you can see some of the trends there. It tends to be more prominent in Black and Puerto Rican children, in boys, and in older children. We don't know what causes asthma in children. We don't know what causes it in anyone, but we don't know what causes it in children. The term genetic predisposition, we've run into that before, and it does not mean that there's an identified gene or chromosome or anything like that, but we know that there's some genetic makeup that would make somebody more likely than another person to ultimately develop asthma. We suspect that that genetic makeup creates some alteration or change in the autonomic nervous system. And that, I think, is pretty logical because the autonomic nervous system is responsible for controlling, dilation and constriction of the bronchioles. So since it's a spasm of the bronchioles, that mechanism makes sense, but we don't really understand the underlying cause of that. And there's also seems to be a pretty big inflammatory component, so we also know there's something related to release of chemicals like prostaglandins or histamines that tend to facilitate inflammation. So with the spasm, of course, the airway opening is reduced quite a bit, and we know that because of the inflammatory component, we get a lot of mucus production. So it definitely is a decrease in the size of the airway. And this causes wheezing when people are trying to breathe in and out. It's going through a smaller airway, so it creates the noise called wheezing. We listened to some of the abnormal sounds last semester. Dyspnea, as you know, is shortness of breath, and of course coughing. So some of the things that we know trigger asthma in children include allergens. Pollens are very high on the list. Animal dander is pretty high on the list. But there are certain foods. Some children are pretty sensitive to, like in the fall when the leaves fall and it rains, and then molds get developed and spores are released. Some are susceptible to that. Just about every child with asthma is going to have a worsening of the condition if they pick up a virus or a cold somewhere along the line. A lot of kids have exercise-induced asthma, where when they try to be active, it triggers a bronchial spasm. Same with weather or climate change. And of course, bronchial irritants are suspected to play a pretty big role. Certainly the incidence of asthma is higher in households where there's smoking going on than in households where there isn't. And we've certainly heard lots of warnings about air pollution, air quality, especially in the summer for people with respiratory problems. And finally, stressors can, as part of the stimulant of the sympathetic nervous system, can certainly trigger bronchial spasm. So for children, we would try to manage this through drugs and to try to promote bronchial relaxation. Corticosteroids are always used when there's a chronic inflammatory condition. It's a powerful way to diminish inflammation. Other medications to like an antihistamine to counter the effects of histamine, other types of inflammatory chemicals. Certainly fluids, we know thickened secretions are much harder to clear from the respiratory system, so we want to make sure we're keeping the child well hydrated. Certainly during an asthma attack, we would want to have supplemental oxygen if that was needed, and try to control any known triggers. Sorry, too early. Just a reminder, when we're talking about impairments and functional limitations or activity limits, an impairment is a physiological change, so posture is impaired posture. You can kind of tell it's an impairment because it says impaired in front of it, but posture is a physiological condition. Impaired muscle performance, joint mobility, range of motion, those are all impairments, as are aerobic capacity and endurance, ventilation and respiration. I guess I don't really have any functional limitations. So functional limitations would be things like they can't run as fast as the other kids during recess, or they can't participate in gym class for a prolonged period of time. They can't ride their bike for a long time. That would be more of a functional limitation. And the goals of physical therapy would be to improve muscle strength and range of motion. We know the importance of thoracic mobility. We worked on that last semester with some exercises designed to improve thoracic mobility, like stretching the pectoralis muscles, doing some segmental mobilization, improving posture. So think for a minute, see if you can remember what's the typical posture you'd see in someone with respiratory problems. Right, you should be thinking about an increased thoracic kyphosis, which kind of would then produce a forward head posture. Some shoulder protraction, scapular protraction, maybe some shoulder internal rotation. So we'd want to work on extending posture to open up the thoracic area. We want to improve the breathing pattern. We know we want a diaphragmatic breathing pattern. What are those other muscles called other than the diaphragm when we use those to increase the size of the respiratory cage? Right, called accessory muscles of respiration. Can you think of an example of one or two? Did you come up with sternocleidomastoid, scalenes, pecs? Good. Improved bronchial hygiene means we want to be able to clear secretions out of the bronchioles so they have better breathing. We want to improve cardiovascular fitness or aerobic capacity. Relaxation is important for a couple of reasons. One, as we said, stress can activate or kick off an asthma attack. But you can imagine the panic someone might feel during an asthma attack when they can't breathe and they can't get their breath. So we need to work on relaxation both ahead of time and during the asthma exacerbation. And that kind of goes along with education and management of symptoms. So you have a case study of asthma. That's actually your first case study. And what we're going to be doing in class is working in groups for you to go through and come up with treatment activities. I'd be thrilled if you looked at it ahead of time and came ready with some ideas. And I want to encourage you to, for all of these pediatric case studies, you need to be looking at the age of the child, the sex of the child, and you need to be thinking about, in relationship to their goals, what kind of activities, fun, engaging activities, would a child of that age and sex want to engage in. So here, for the case for asthma, we have a 3-year-old girl. So you need to be thinking about what are the fun things that would engage and keep a 3-year-old girl entertained, and then figure out how you could modify those activities so that they are going to help that child meet those goals. Yep, this is why pediatrics is challenging. Plus, kids like to do lots of different things, so you got to have a lot of activities. You can't just have one or two. You got to be prepared to switch activities quickly if they get bored with the first 4 things you came up with. All right, then we're going to go on and talk about cystic fibrosis. We briefly mentioned this last semester as well under the umbrella of COPD. And remember, this is a genetic disorder. It's a disorder of the exocrine gland. So it has system-wide complications. It affects sweat concentration. It affects nutritional issues in the intestines, and it also affects the lungs. And in physical therapy, we deal primarily with the lung issues, but of course we also have to pay attention to nutritional issues for energy and for growth as well. It is an autosomal recessive genetic transmission, and they have identified a gene on chromosome 7. There are many mutations of this gene. So things have really changed, from like 20 or 30 years ago. 20 or 30 years ago, any child born with cystic fibrosis was probably going to not survive past their teens. And that's changed partly because of medical advances, but also because we have a lot of different mutations and a lot of variation in how cystic fibrosis presents. But this is just a little, you might have done this again in high school or something, taken the, what color beans or flowers are going to get created. But again, since it's autosomal recessive, you need both the mother and the father need to be carriers. In other words, they'll have the gene, but they won't demonstrate the disorder because it's recessive. You have to have both to actually have it. So they would at any time have a 25% chance of having a child with cystic fibrosis. So again, you'd have 25% chance of having a child who was not affected, 50% chance of having a child who was affected, and then 25% chance of having, 50% chance of having a child who's a carrier, and then again a 25% chance of having a child who actually has cystic fibrosis. So I want to talk a little bit more about the pathology. The gene affects a protein that limits or prevents chlorine from being able to enter into the cell. And that's, of course, if you think about cell membranes and ions going in and out, since chlorine can't go in, more sodium goes in instead. And where sodium goes, water goes. And so if all the water is going into the cells, then there's not enough fluid outside the cells. And so in specific areas in the body, it creates a lot of dehydration. So the mucus in the lungs becomes very thick. In the pancreatic ducts, it's an issue. And again, in the intestines, secretions are very thick. And so I think we understand the lung function a little bit better, at least I do, than the intestines. But definitely affects the ability to mobilize secretions and to clear them. And so we end up with a lot of blocked bronchial tubes because of this thickened mucus. The other thing we see is also a change in or a decrease in pancreatic enzymes, again, which are important for digestion and nutrition. So the symptoms we see in the child is a productive cough. Productive meaning when they cough, stuff comes up. They have abnormally frequent and large stools. So in other words, a lot of the food that's going in, because of the thickened mucus lining within the intestines, they're not able to absorb the nutrients. So they pass through a lot of the food that they eat without absorbing and getting the benefit from it. And that results in what's called a failure to thrive, just a stunting or a diminishment in the growth and development of the child. Probably no surprise to you that they have recurrent pneumonias, because when that mucus is blocked, it's prone to becoming infected. Rectal prolapse is a collapse of the rectum, so because the stools are so large, they kind of stretch out the smooth muscle and soft tissue, and then it can actually collapse in on itself. I can't say I know anything about nasal polyps. Clubbing of the digits, we did talk about that last semester, and that's just a symptom that we see with anyone that has a chronic hypoxic condition. So in the lungs, again, particularly, we have lots of thick secretions, increase in number and size of the goblet cells, so that just intensifies that problem, leading to airway obstruction and infection. Bronchiectasis. Remember what that term means? I don't know that we talked about bronchiectasis. We talked about atelectasis. Do you remember what atelectasis is? Atelectasis is a collapse of a lobe or part of a lobe in the lung. So what would bronchiectasis be? You're all so smart. Yes, collapse, partial collapse, a collapse of an area in the bronchioles. There's lobar atelectasis. Pneumothorax, hemoptysis, blood in the sputum from all the coughing. And because of the chronic nature of this, the buildup of mucus increases compression or pressure on the vascular tree that goes through the lungs, and so that's going to create pulmonary hypertension. We know people who have pulmonary hypertension for a prolonged period of time can end up with heart failure, right-sided heart failure, and we call that right-sided heart failure cor pulmonale. So I know this is always confusing, and this is probably a good review, but if you picture the right the right ventricle is pumping to send blood through the vascular system, through the pulmonary vein in the lungs. If it's always pumping against high pressure, ultimately that right ventricle can wear out, and so that's when we would get cor pulmonale. So our medical management, we definitely want to decrease airway obstruction and pulmonary infection, and so we may have to use various medications, and they do enzymatic replacements to try to improve the nutritional status. And of course, with any chronic disease, especially when starting in childhood, you definitely need a lot of psychosocial and emotional support. So let's look again at the impairments and functional or activity limitations. Impaired posture, so same thing that we just talked about with asthma, and impaired muscle performance, in other words, decreased strength and endurance of muscles, joint mobility, range of motion, aerobic capacity and endurance, and ventilation and respiration. Doesn't that all look very similar? So again, there really aren't any functional or activity limitations there, but again, we could think of some. So if we look at our next case study, which is James, a 10-year-old boy with cystic fibrosis, his goal is to play soccer. So his functional limitation would be the inability to run for long distances or long periods of time. That would be an example of a functional limitation. So our goals, again, very similar to what we just talked about with asthma. So I want to show you one handout that I've seen from the Cystic Fibrosis Foundation, and they kind of take you through the life of a 7-year-old with cystic fibrosis, and it's a great way to kind of encapsulate everything these kids have to go through. So wake up coughing and take the following medications before going to school. 5 enzyme pills, so those are what we were talking about to support digestion. Vitamins, allergy medication, Prevacid for antacid, nose spray, maybe the polyps are because of the mucus problems in the nose. Pulmicort through an inhaler, that helps, it's a bronchodilator. And then 20 minutes on a nebulizer to inhale more medication. Keep eating those enzyme tablets. Afternoon, physical therapy. Somebody banging on your chest in all different positions to clear the airways. Bedtime, saltwater squeeze, more squirts of nose spray, drink Zyrtec, 30 more minutes on a nebulizer, and this is when the person's healthy. And I may have shared with you before that at one point a few years ago we had a student, an adult student in our program who had cystic fibrosis, and she was late 30s, early 40s, and so she would describe her routine, and it sounded pretty similar, and but she would say it would take her 2 to 3 hours a day. That's how much time she invested just to stay healthy. And then the times when she wasn't as healthy, it was a lot more time. So think about a child having to manage this, and so when we think about that emotional and psychological support, that's very important. And of course we can't forget about the parents in the family who are really managing all this. So from a physical therapy standpoint, let me go, there we go. Positive expiratory pressure. This helps with exhalation. It's kind of like doing a pursed lip breathing, where they are able to inhale pretty easily through the one-way valve, and then when they exhale, it creates resistance or even a little bit of vibration. So helps to open up those airways. We've talked about that with emphysema last semester. I'll go back here. We know postural drainage and percussion definitely would need to be done. So these kids, it's pretty much going to need to be done on all areas of the lungs. So they would do it every day, but they would kind of rotate the areas of the lungs that they would do, just to have they'd kind of have a system so that, over the course of a few days they'd get all the areas. A little easier to do it with a smaller child than it was to do it on each other, but still would need to be done. This is inhaler treatment, so it's a way for them to get medications in, to inhale those medications that are going to help thin secretions, diminish inflammation in the bronchioles, and also to dilate the bronchioles. The little girl on the left is wearing a vest, and that's a vest like this, which does high-frequency chest oscillations. So it's essentially providing the vibration that you would get during percussion and vibration of postural drainage. So the child, and I didn't find another picture. Here's one of another one with a child. So they may assume some postural drainage positions, or they may just be in any posture, any position, and have it on. So you can see he's just kind of hanging out playing with his Legos during the time that he needs to be undergoing his oscillation treatment. So same idea, it vibrates to loosen secretions to try to keep the secretions mobilized so that they can clear them out of their lungs. So you do have, as I mentioned, a case study for a child with cystic fibrosis as well. I do just want to mention that while certainly vibration and postural drainage can be important adjuncts, and I believe they are commonly done, there is some evidence to show exercise is also effective in clearing out secretions. Certainly we would want to incorporate activity for all the additional benefits of muscle endurance and aerobic capacity improvement. The other thing we have to make sure of when we're doing any kind of physical activity with kids with cystic fibrosis is make sure that we do give them enough electrolyte and nutritional supplements. So this is the